All right, I want to welcome everyone back to Hand Therapy Briefs. As you're signing on, if you can take a minute to post in the chat where you're joining us from, that would be wonderful. Today, we've got a really great session. We have two individuals that collaborate closely in working with patients that have sustained upper limb amputations. So we have Sarah Matthews of Hanger. She's a prosthetist and orthotist. And then we have April Meyers. She was a virtual hand to shoulder fellow who's now a CHT. She's right across the street from Hanger at Select Medical in Tulsa, Oklahoma, and they've been working closely together with patients. So I'm going to let you each just tell us a little bit about yourself and how you got interested in working with patients with amputations. And why don't we start out with Sarah?
All right. Hello, everyone. Thank you for having me. So as she already mentioned, I am a prosthetist and orthotist. I do probably 60 or 70% prosthetics, but then also do still see some of those orthotic patients. And here it's really been in the last couple of years that I've really taken on the role of seeing more upper extremity prosthetic patients. I've been in the field for about 12 years and worked in various areas. I did my residency in the Kansas City area, worked in Wichita for 3.5 years, and then have been in Tulsa ever since. So, really enjoy working with this patient population. It's just very different and challenging, and there is nothing similar about anybody really. Everything is always ever changing, and the technology has just really changed and evolved in the last few years too. So it's just been really interesting and kind of fun to do.
You guys pretty busy? We're excited to hear more about it. As you are all joining, just make sure that you're muted. I'll mute people as I notice that you're not muted, but it'd be helpful just to eliminate background noise if you do that. April, why don't you go ahead and tell us a little bit about yourself as well?
My name's April. I've been an occupational therapist for almost 10 years. In 2020, I decided to go through Morella's program, which turned out to be amazing. So I'd wanted to be a CHT for a long time, so I decided to hop into her program. And after successful completion, I was able to pass the CHT exam on the first try. So since then, I've been practicing now as a CHT, and I've been developing a relationship with Sarah at Hanger. I have a passion for upper extremity amputees. I've worked with a lot of different injuries, as you can imagine, but I find that amputees are a special population, and a lot of them don't get the kind of therapy or the close care that they need. A lot of therapy programs just don't give enough education for therapists. So it's kind of one of those things you get thrown into it. And by working with Sarah, I've been learning a lot about prosthetics and how to check if they're fitting correctly and how to rehab patients.
So can we start with that then, April? You said in terms of patient care and maybe some gaps in care generally speaking. Can you talk a little bit about what those special needs are and what support really is needed to help optimize their outcomes?
It depends if they're coming to therapy pre-prosthetic or post-prosthetic. You know, we can get patients right after amputation that need all of the basics, which I think is mostly what is covered in therapy school for desensitization, wound care, phantom limb pain, things like that. Once they have gone through the entire prehab process, that's when they would go to Sarah for a prosthetic fitting. So when they come to therapy after prosthetic fitting, research shows that there's a lot higher chance of rejection of a prosthetic if patients don't go through rehab. You know, it's frustrating. It's not their hand or their limb. And if they can't figure out how to use it, they'll, throw it in a corner and not use it. So my goal is to work with Sarah to help incorporate that use of the prosthetic for the patient. And you would be surprised. I've talked to countless therapists that know nothing about prosthetic rehab. They just know the the immediate amputation kind of rehab. And there's a lot of nuances that, I didn't even know until I started working with Sarah. I mean, you have to deal with proper fit. You have to help patients learn to use their prosthetic without abnormal movement patterns. You know, people try to compensate in all kinds of weird ways, which can create secondary issues later on down the line.
So can we talk about the process then from that acute phase? You know, how are you incorporating prosthetic readiness? What kinds of maybe psychosocial sequela might you be dealing with even early in those early phases? And also working in that area of psychosocial sequela, how are you readying them for the use of a prosthetic? Because I would imagine that that's happening with you in those early phases, maybe as an overlay to working on things like tissue healing, that would be occurring concurrently.
It does. I mean, as we go through the pre-prosthetic process, usually that's when the amputations are still fresh. You know, a lot of patients have a difficult time even looking at their hand. So really, we have to help get them to a point of acceptance, you know, where they can slowly start looking at their hand, touching their hand, and feeling that it is part of their body, you know, whichever part may be left. So it's really just a gradual process of acceptance. And a lot of times, you know, therapy isn't just physical at that point. You do a lot of kind of a emotional cognitive rehab in a lot of ways. And I know Sarah does that too when she's actually fitting patients with prosthetics. You know, she does an in-depth kind of analysis of what prosthetic may be best for that individual based off of their desired tasks, either at work, IADLs, day-to-day life.
And where does Sarah come into this? You know, is the patient referred to you from the surgeon, for example, and like hanger hasn't been brought into the picture yet, or is it something that's initiated simultaneously where the prosthetist is contacted, you're contacted to initiate care? Is care initiated simultaneously? How does that work in terms of the
It can go both ways. So, you know, sometimes patients are sent to me that have nothing to do with Sarah after an amputation. And then when they get to the point where I feel that they're ready for a prosthetic, you know, patients have choices of who they go as their prosthetist, just like people have as therapists. And Sarah is one of the very few upper extremity prosthetists in this area. So usually I try to, you know, send patients to her at least for an initial evaluation or to kind of see their different options. I keep brochures in the clinic and her phone number and everything. And I kind of give them a mini education on what the different prosthetic options are. And then on the reverse, sometimes Sarah gets patients that have already gone through rehab, maybe with a different doctor or therapist. They go to her for a prosthetic. And then after get the prosthetic, she'll send them to me for actual therapy, knowing that I'm one of the few therapists in town that does prosthetic rehab.
Gotcha.
Yeah.
So turning things a little bit over to you, Sarah, in terms of how patients are referred to you, obviously, you know, if they're coming from a therapist's recommendation, but what about, are they referred from physicians, maybe pre-rehab? Are you seeing them prior to any kind of physical rehab?
I would say most of the time they have been given at least the option for some type of rehab prior to coming to see me. Whether or not they actually followed through with that or not is kind of the big question. With upper extremity amputations, though, they are primarily traumatic in nature. So a lot of these cases are work comp related. And anytime it's a work comp related injury, they're almost always going to get pre-prosthetic therapy, which is nice because they can start working on that desensitization. But every once in a while, we will get some referrals directly from the surgeon. You know, maybe it's somebody who had an amputation years ago and they maybe all of a sudden now just want a prosthesis and they had to go back to the surgeon to verify that they could. You know, sometimes we do get those direct referrals, or if it just got missed, you know, with the amputation being traumatic, a lot of times those patients are in and out of the hospital so fast that I think sometimes the therapy component can kind of get slipped through the cracks and they go, okay, well, just come back and see me for your follow-up. And then they haven't had any desensitization, they haven't had any shrinkage, anything like that. And then they're being sent to us. So for the most part, I would say there's a good amount of them that get the pre-prosthetic therapy, but there's a few that don't, and we'll see them without any kind of therapy background.
Okay. So in an ideal world, if it's a post-trauma, they're still kind of in those acute phases, they're going to the therapist first. They're going through the rehab, which makes sense. So then,
Yes.
April, can you talk a little bit about the acute rehab components and just kind of through the trajectory towards readiness for referral to Sarah?
Yeah. So depending on how acute they are, I may be seeing patients still that have stitches at their residual limb site. So, we work with wound care. We work on desensitization, scar management, edema wrapping to try to keep the limb, from getting swollen. You want to avoid like these little dog ears kind of at the end, and you want a nice round limb, so it's more comfortable for the prosthetic. And then after, the desensitization phase and the scar management, edema shaping, I also work on, depending on what they have left of their arm, trying to do different tasks without a prosthetic. Patients that have prosthetics like to do things with and without their prosthetics, depending on what they have to use. So when they have enough ability to tolerate touching and a little bit of pressure, that's when they usually are ready for a prosthetic. I do know that Hanger does make kind of pre-prosthetics, though. It's really common for them to go to hospitals right after an amputation, especially lower extremities, where they make them something to go on their leg. And patients have a better readiness for prosthetics if they have that pre-prosthetic, because it kind of gets them used to touching things and feeling it, and the mental idea of having a prosthetic.
So with regards to getting them to use their residual limb functionally, can you just like a quick rundown in terms of if someone has a certain level of an amputation, the kinds of functional things that you would educate them to do? So most of the amputations, are they at a particular level? Is there a pattern with what you see in terms of upper limb amputations?
I'll actually let Sarah answer that because she probably knows the statistics a little bit better than I do.
Sure.
Yeah, so partial hand is actually the highest incidence of amputation level of the upper extremity, but it is also the more difficult level to actually fit prosthetically. And then the transradial is probably next, transhumeral, and then the really higher up, the four-quarter amputations are definitely lower incidence, especially in terms of the users of prosthetic devices. But partial hand is, I would guess that's probably what April sees probably the most of, especially with work comp situations, because they're either getting all fingers, part fingers, but that's the most common level of injury for the upper extremity. And then I would say transradial is probably the next most common that she would probably work with.
In terms of acceptance of the prosthetic, is there any correlation with the level of injury with their likelihood to accept the use of a prosthetic?
There is a little bit, but a lot of it really comes down to more of their training, honestly. Was the fitting good? Did they have somebody who was knowledgeable in what they were doing for the fitting? And then did they actually get the training afterward? Because as April was saying, if you don't get the proper training, they're more likely to just toss it in the corner. And so that's probably been one of the biggest things that we in our relationship building here is just really trying to work together to make sure that they get over to someone like April, so that way they can actually work through those frustrations, because there's going to be frustrations. We have a user that we've seen together, and he's phenomenal at what he can do, but he still goes to therapy on a very regular basis, just to make sure that he is not fatiguing or not wearing out or getting frustrated with the types of activities that he's doing. So it's not even just a one and done, that they say, okay, you're going to go to therapy for 6 weeks after you get your prosthesis and then you're done. It really should be kind of a continuation, that they kind of follow up as they change activities or maybe even change devices. Because, for instance, what I always kind of tell my patients is upper extremity prosthetics are more of like a tool. So there's not one prosthesis that is going to be ideal for every situation. So in those circumstances, what we do is we set them up with the most appropriate for what they want to do immediately. And then hopefully down the line, we can get them another scenario to work with as well. Well, that would be another scenario where they need to get back into therapy so they can learn the differences and the little nuances between the two. And again, to avoid that frustration and actually get good use out of their prosthesis.
In terms of access to the prosthetics, in terms of insurance coverage, and like, what are the resources available for patients so that they have that opportunity?
Yeah, so that can be a little tricky. Most insurances, private insurances, will cover some type of prosthetic device. But you do have to be careful in what you discuss with them and making sure that it's covered in their plan. Because, for instance, some will only cover, say, the body powered, or as some people know it, is the cable driven type prosthesis. So versus the myoelectric or the external powered type, they might be excluded from their particular plan. And then it also depends on state to state. I don't know how many different states are represented here, but for instance, in Oklahoma, our Medicaid program only recently started paying for adults to have any kind of prosthetic coverage. And in the lower extremity, they actually do a fairly decent job of giving them what they're needing. But in the upper extremity realm, it is pretty clear cut. It is body powered or cable driven only. No exceptions. They're just not coming around to the technology, which can be a little bit more difficult when it comes to the partial hands as well, because it comes into coding situations that can get tricky. But when they don't have a specified L code that we bill through, and it's a miscellaneous code, insurances sometimes are not so apt to cover those because they think they're quote unquote experimental.
Okay, so then April, that's something that you would have to be knowledgeable on in terms of not, when you're educating them to the potential transition to the use of a prosthetic, not being so specific, knowing that their options might be limited.
And I kind of give them suggestions based off of what their insurance is. A lot of these upper extremity amputations are work comp and traumatic. They usually have a little bit more access to all of them. So I can show them more prosthetics that are available to them or could be available to them. Somebody that might have Medicaid, I wouldn't necessarily go into all those options.
So can you talk a little bit about, from a therapy standpoint, the physical readiness for the transition to prosthetics, and then also the psychosocial support that's needed after an amputation? What does that look like in terms of intervention? So we've got the physical and the psychosocial.
Physically, I'm looking at the entire extremity as a whole. So if it's a partial hand amputation, not only am I doing rehab and desensitization of the hand, I'm usually doing strengthening of the forearm, bicep, triceps, shoulder, because those are prime movers and everything gets debilitated once you have an injury and you don't have full use of it. As far as psychosocially, I find that patients that have a good support system at home do a lot better. Patients that don't have as good a support system, you're not married, have no family, they usually struggle a lot more with readiness for a prosthetic and just having an amputation in general.
So maybe now, between the two of you, can you describe maybe a patient that struggled with the acceptance of the prosthetic, and how did you manage that?
I don't know if we're both immediately thinking of the same person, but there's one in particular that's she's a quad amputee, and she, due to her limb shape and also just her readiness and her insurance, we did go with a body powered system to start, but she has been very resistant to really engage with them. She feels like she's extremely limited with them. I don't think she still is even wearing them as much as we would like her to also just kind of ready her limbs for the option of the myoelectric prostheses. But, and she has a wonderful support system. She has a great family component. She is by herself a lot with her young daughter, which I think adds a little bit of complication there. But I mean, she's kind of really just poured her heart out to April and I from time to time about what she can and can't do, and you know, her struggles. And so it's interesting. I think all of us kind of take on the role of a therapist, and whether that's even just listening, not even offering any advice, but just listening and being an ear for them is a huge thing. But I mean, she's one that we're still working with, and you know, April's offered to show her and offered videos because there's another component there. She moved to Missouri, and so she doesn't have easy access to either of us right now. And so, but she still wants to come back and see us. So I don't know if you want to take off from any of your thoughts on that one too, but
I've had multiple conversations with her about what she can and can't do with and without the prosthetics. And, you know, she has 2 body powered prosthetics. I think one of the things that she struggles with is how it looks. You know, she wants myoelectric prosthetics because they look more like hands when those are actually heavier and sometimes don't work as well. You know, when a patient starts using myoelectric prosthetics, they actually have to do therapy beforehand with myocyte testing, you know, so wrist extensors and flexors, you know, you're putting little electrodes to get them to learn how to contract those muscles without co-contracting, you know, wrist extension and flexion at the same time. And that can take a lot of time. And it can be difficult. And for her, you know, she's just wanting to jump in and try to regain some semblance of her former life. And she has a small kid. So, you know, that's why, you know, Sarah and I have really pushed her to get good with the body powered prosthetics because she's going to be able to do the most, at least in the beginning, with myoelectrics as an option later on down the road. I mean, she's just, as you can imagine, being a quad amputee and she's pretty young with a child is just, I mean, it's devastating, you know. So some days she comes to therapy or I'm there with Sarah and she's on top of the world and doing great, and other times it's just, you know. And that's kind of the roller coaster that we have with amputees, you know, good days, bad days, whether you have a good support system or not. So it's really about being understanding and, you know, sympathetic to, you know, how their life is different now. It doesn't look like your and I's life anymore.
And they're essentially relearning how to do everything.
Yeah.
And there's a lot of effort, even just mentally. Yeah,
right. Well, and I know that Sarah was having a difficult time even with her lower extremity prosthetics because she's below the knee. So she wanted to just kind of walk on her residual limbs. Well, that can create problems so that the lower extremity prosthetics aren't fitting right. And then it's more difficult for her to wear them for comfort. But, you know, she's just kind of in survival mode. Like, I just want to be able to move around and do a little bit. So it's a challenge.
So as we near the end of our 30 minutes, if you have questions, go ahead and post them in the chat. There's one question in the chat. We can see if they can answer this for you to hear. He says he has a patient who was hit by a bullet. His D3, D4, D5 are amputated, lost his job because of disability. How can he be supported in terms of getting the hand back to being functional? So I mean, since we're talking about prosthetics, and I'm not sure, you know, if prosthetics are an option for this patient to hear, but why don't we just focus on the prosthetics? You know, what would be your recommendation for this kind of an amputation in terms of a prosthetic? Would you recommend one? Yeah.
Yeah, kind of a loaded answer, because it just really depends on what the residual limb looks like, and where exactly that distal amputation was. Because there definitely are options out there that can be functional, that are more kind of a body powered or motion driven type of prosthesis that would give function back. And then also, I don't know if he can respond real quick if it was his dominant side or not, because that plays a really large role too, on whether or not we truly just need, say, potentially a passive device that could just provide some support to the dominant side versus it being the dominant side. But there are definitely options getting into a prosthetist so they can actually visualize the limb, see what they have to work with. I just wouldn't want to guarantee types of prosthetic options without knowing exactly what the residuum ends up looking like. And then also the other situations, as far as wrist motion and those types of things, because all of that can be affected and affect how the prosthesis would fit or what options that they would have.
And April, just from a clinician standpoint, knowing that the patient has his thumb and his index finger, because I know you've talked about, working with residual, whatever residual limb is there functionally, what would you recommend for this patient? Presuming that his wrist is intact, that there's just the loss of the 3 ulnar digits.
I would teach the patient, how to use this with day-to-day life, and then using that ulnar side of the hand to kind of help palm and use the opposite hand as a way to cradle and hold things. I actually had a patient who had all digits on one hand lost, and she only had a palm left. And then on her other hand, she had partial amputations on all fingers except her thumb. And she was actually very successful in being able to learn how to adapt, because she did have one full thumb and then partial digits in the other hand, as well as a palm, opposite to pick up and do things. So I would just focus on what they do have, and how they can use their other hand as like an assist for things.
And just as one final question, and then I'll get to this last question. Like, for someone with the partial hand amputation, like this patient, having worked with patients using prosthetics, do you see that they get good functionality with those finger prosthetics as compared to using just, the residual digits?
I've seen both. That one patient I spoke of with all of those missing digits, I actually referred her to Sarah to get a prosthetic, and she actually decided she didn't want one because she felt like she had enough function, with what she did have versus getting a prosthetic. And then, I've also had a patient that's had a prosthetic that's just kind of slides on like a glove for the 2 fingers he had missing, and he could kind of like ratchet it down, but he was like a laborer, manual laborer, and he had to have it to work, and he could work quite successfully with it.
Okay. That kind of, yeah. So I would say for Tahir, just looking at what options are available for that patient related to prosthetics, and then just, working like April suggested with the residual function, his patient has to go back to work. So I think that's the issue. Another question in the chat is, what has been your biggest challenge as a therapist working with patients with amputations?
I think it's loss of limb and learning to accept that their life is going to look a little bit different. I think we all have a hard time accepting change. And when it's a forced change like that, it's like losing a loved one. This is something we've always had. It's just always been there. And when you lose it, life looks totally different. And so just learning to accept with their new reality is a big challenge.
Yeah, and I always think, the word acceptance always, to me, can have a ring to it, like a sound, as though we have to accept less. But I think if we can educate patients that acceptance isn't accepting less, it's just adjustment, really, is what we're talking about.
Right.
Getting adjusted to navigating life, with whatever, residual limb that they've got, it's a learning curve.
Well, what happened?
So once they go through that learning process.
What fraud?
Any other final questions? I hear some background noise. I'm trying to mute.
From at least from a therapist perspective, just remember to be respectful of the individual and don't get frustrated, because I mean there's been times when I give patients, hey, you should try this or this or this, and they're just like, that doesn't work for me.
Yeah.
One thing does not work for everyone, and just because you can't answer the question for the patient doesn't mean there's not an alternative.
Absolutely.
So I'm always trying to find new ways and researching and talking to Sarah, and I look up limb amputees on YouTube and online all the time to see how different people do different things based off of their level of amputation.
I think that's a great suggestion, because there's so many people that kind of put it out there in terms of what it's like to live with an amputation. They're sharing that information. I think that's a great resource, to look at people's subjective experiences. Another question, any favorite products you use for scar management or shaping residual fingers before prosthetics?
As far as what I've used, I like using those Slipos digital caps.
Yeah.
You can also use specific kinds of Coban if you know how to wrap it correctly. There are incorrect ways of wrapping residual limbs that can create issues. So as long as somebody helps educate you on that, and I would just encourage you to get plugged in with your local prosthetist, because it's amazing like how much we learn from each other just by talking and interacting, things she didn't know from a therapy perspective, and I certainly didn't know from her perspective.
Absolutely. And sometimes depending on if it's, a lower level digit amputation where maybe just a little bit above the MCP is there, sometimes we can even use gloves, compression gloves, and then sew them and stitch them. So, and that's probably something that I'm guessing therapists don't have on hand. But again, like April just said, get in contact with the local prosthetist and ask them if they can help you out with some of those things.
Wonderful. Well, thank you so much. This was so good, and I appreciate both of you joining today. And I want to thank everyone else for joining as well. We have a couple more of these hand therapy briefs, so hopefully we'll see you next week. Thanks again, both April and Sarah.
Thank you.
Have a great afternoon, everyone, or evening.
You too.
Mm-hmm.